So here at AHA Sessions 2018 and published simultaneously online, we had the presentation of the new 2018 cholesterol guidelines that were sponsored by the AHA and the ACC. I think we see a number of new things, and I'll just kind of run through the patient groups quickly. In secondary prevention, we provide specific recommendations about after you've used maximally tolerated statin therapy, if you haven't seen the 50% reduction we're looking for, and particularly if the LDL cholesterol remains above 70, that's the threshold where we could consider adding first ezetimibe, and then if you still haven't achieved those thresholds, second, consideration of a PCSK9 inhibitor. But we really focus on the value, the cost effectiveness being highest in high-risk patients with secondary prevention needs. For patients with LDL cholesterol over 190, likewise, we're looking for maximally tolerated statin therapy. If we haven't seen the 50% reduction and or if the LDL remains over 100 in those patients, then we're looking to add ezetimibe first, again, much more cost effective, and we're looking hopefully for a big reduction in LDL there. But if the LDL remains over 100, reasonable to consider adding a PCSK9 inhibitor. So for the first time in the guidelines, we really have formal guidance on how to use those medications and in what order. And we know that all three classes are now efficacious when used in those patients. For patients with primary prevention needs with diabetes, you don't need to initially do the risk assessment. Start a moderate intensity statin for all patients with diabetes. And then if they have high-risk features, longer duration of diabetes, 10-year risk estimate over 7.5%, things like that, reasonable to actually move to a high-intensity statin. Finally, for primary prevention patients, we provide a process of risk assessment. It's not just calculate and diagnose. It was never that, but we've actually tried to provide providers and patients with the opportunity to engage in a process of risk assessment. So yes, use the pooled cohort equations to estimate the 10-year risk. And that starts a clinician-patient discussion where we consider, are there modifying or risk-enhancing factors? Family history. Are they from a particularly high-risk race ethnic group? Do they have chronic kidney disease? All sorts of different things that are laid out in the guideline where we would say, we might actually be under or perhaps overestimating this patient's risk. That helps shade that initial estimate. And finally, if we're still on the fence, in intermediate risk patients, that's a 10-year risk of 7.5 to 19.9%, we for the first time formally recommend in that group with a 2A recommendation, coronary artery calcium measurement to really help reclassify patients. Because we know if the coronary calcium is 0 in an intermediate risk patient, their event rate will be very low, and we provide specific guidance on avoiding or deferring statin therapy in those patients. If the coronary calcium is over 100, that's clearly a benefit group. We want to put those patients on statins. And in the middle group of 1 to 99 coronary calcium score, it's really clinical judgment. The patient does have atherosclerosis, but if they're really averse to starting a statin today, then what we would recommend is they at least get good follow-up, perhaps a repeat CAC measurement in 3 to 5 years, and then you can reassess and move forward. So those are the major things that are new in the cholesterol guidelines. I think it's a very important step forward and really provides resources and tools for clinicians to take much better care of their patients.